Hey everybody, and welcome back. I hope everybody had a good break. We're going to go ahead and get started. This is the lecture for chapters 1 through 3. It's really just an introduction to families, communication, and the nurse's role during childbearing. Okay, so let's take a minute and talk a little bit about maternal and child health through the years. Now, prior to the 20th century, basically you had your baby at home with the help of female relatives and or a midwife. There were a lot of problems that occurred during these times and during home childbirth because women died more easily, as did infants. We weren't able to give them the supportive care that they can get now in a hospital, prenatal care to help ensure the viability of the fetus and the health of the mom. So many women died in childbed fever. You had a baby, usually you laid around for a few days. If you had a tear in your perineum when you were having the child and you went to use the facilities, which was probably an outhouse, think about all of the germs. These women would get these germs into that wound area, in the peri area, and then end up with an infection that usually led to death because we weren't using antibiotics as widely as what we are now. We didn't know about the aspects of good hygiene and indoor plumbing and how that played into effect with infection and the transmission of diseases. Another problem that occurred was a hypertensive crisis, preeclampsia. We didn't monitor these women for their blood pressure. So if they had preeclampsia, a lot of times they died, and that was very, very probable. You could have infants that were premature, that were born too early, and needed special care. Usually these infants died if they weren't, not too early. If they were a month early, usually they were okay, but you start getting these preterm infants that are around 28 weeks, and they need a lot of support in order to survive. So you just didn't have that. So we had a lot of moms die and a lot of babies die, and before long, government and society started seeing these trends and wanted to do something about it. So we had changes happen in healthcare, not only with women and children, but through all age groups, because we had technological advances. We broadened our knowledge base. The government got involved and started things like the FDA. We started things like prenatal clinics or clinics for mothers. And then you had a rise in consumer demands. As we get richer or as we have more money and more free time, we tend to buy more things. We want the latest gadgets or the latest technology to spend our money on. And so this was an area that has really been consumer driven, especially once women gained the vote and were seen as independent individuals. They wanted control over their bodies and they wanted choices. So this helped drive the demand for new products. So also in the past, even with early MD assisted labors and births, you still had problems, and this is an issue we're going to talk about today, the problem with midwives. Midwifery has become very popular. Home births have become very popular. We're going to talk about that. And most physicians are very resistant to this. They feel like they're the experts and they should be the ones present for the birth. So we come to the three parts of pregnancy, which is antepartum, intrapartum, and postpartum. And those are the major content areas that we are going to be looking at during the next couple of weeks. So, technological advances, what does that include? Well, that's things like screenings and diagnostic tests. Think about all the screenings and diagnostics that a pregnant woman goes through. We have ultrasound, we have glucose tolerance testing. We have pregnancy tests that you can buy over the counter. We have ovulation tests that you can buy over the counter and make more informed decisions regarding health and pregnancy. Increasing knowledge. We're asking why. Why do these things happen? Why are these mothers dying? Why are these babies being born too soon? Government, like we said, they looked at things like, why are all these mothers dying, or why are all these infants dying, and what can we do to help prevent these mortality rates? So childbirth settings, as I said, prior to probably 1900, the only place to deliver a child was at home. You were at home, you were surrounded by your female relatives. There normally wasn't a doctor at a birth. You would have a midwife, or you would have a mother or a grandmother or aunts who had been through childbirth and knew what to expect, and stayed with the female and helped with the process, and then helped with getting settled afterwards, and what to do, how to feed them, how to take care of them, problems that you might see. But today, the majority of births occur in a hospital. So sometime around the 1930s, 40s, you started seeing an increase in children being born in a hospital. Physicians took over the job of midwives and female relatives. And now it's very common. That's the most common place to have a baby in the United States, is in a hospital. So within a hospital, you have different areas that you might be in when you are having your baby. Most common is you go in one room to labor, and then when it's time for you to deliver, you go to another room to deliver, and then they take you to yet another room to recover. The move nowadays is to have labor, delivery, recovery, and postpartum all in the same room. So we have these birthing suites now in these big hospitals. Think about St. Vincent's Medical Center East. Everybody knows that babies come from St. Vincent's. Okay, that is their commercial. They are really pushing for that segment of the population to come to their hospital and have a baby. And their rooms are like the rooms you see here on the screen. Everything is in one room. Your baby never leaves your sight unless there's a problem. And then we have cesarean birth, where you actually have to have a surgical procedure in order to extract the fetus from the womb because of either complications, problems that exist, or it can be elective. And that has been a problem that is being addressed in the United States through Joint Commission, is how many elective cesareans does a hospital do, and why? Is there a medical reason to do a cesarean birth? Because look at all of the complications that are related to surgery that set you up for problems. We're making an incision, we're cutting the skin, and remember that's the first barrier for germs. So you have an increased risk for infection. We're giving the mom all of these drugs, and some drugs are good, but not all of them are. So we are exposing the mother to adverse reactions from drugs. So, we have to take all those things into consideration. Normally, Childbirth is viewed as a natural process. The mother is not sick. There's nothing wrong with her. She's just pregnant. Now, that doesn't mean she doesn't have other disease processes going on that may make her sick or unhealthy while she's pregnant. But in a healthy female, there really doesn't need to be a lot of intervention during that process of being pregnant and going into labor and delivering the baby. But, you know, we know that things happen. We have a lot of comorbidities today with women. We have a lot of risk factors that we have to take into consideration when a woman decides or gets pregnant and has a baby. So that's within the hospital. There are places to have a baby outside of the hospital setting, and these are like birth centers. And birth centers are basically freestanding facilities. They usually are associated with a hospital. They don't have to be. But this is a place where a woman who has low or no risk during her pregnancy can go and deliver her baby. These centers are not equipped to handle high-risk pregnancies or complications. And that's really why you want a hospital associated with these birth centers, because things can go wrong when you don't expect them to. So you have to be able to get that emergent care that may be needed if a complication occurs. You can have home births, and this is becoming really popular, especially out west. We have a new generation, I don't want to call them hippies, but earthy type people who see pregnancy and birth as a natural process. They want to be at home in their own surroundings. They want to be able to call the shots and be in control and have whatever family or friends there that they want and not be restricted. And I think this is a great idea because a birth of a baby affects everybody in the family. But home births are not for everybody. And depending on where you live in the United States, it's not feasible to have your baby at home. In the state of Alabama, they don't use and they don't certify midwives. That they're only starting to do that now. And so if you have your baby at home, you may not have a trained professional to be there with you. There are women who drive across state lines in order to have their baby with a midwife. And so I think that times are changing, and we are going to have to look at this and look at the feasibility. Because having your baby at home is also less expensive. You don't incur all of those costs associated with being in that birthing suite at a large hospital and using all of those professional hours, such as nurses and doctors and techs, that you have to pay when you're in the hospital. So, you know, some people just don't have the money, or they don't want to spend their money on that. They want to do it more naturally. Okay, so current trends in healthcare. We've all heard about the Affordable Care Act, whether you've heard it's good, it's bad, whether you think it's good or it's bad. Everybody has an opinion about that, and I'm not going to debate it here. But we do have health care insurance. There are different types of insurances, and these are some of the types. There's actually a handout in Blackboard under Introduction that talks about HMOs and PPOs and what the differences are between them. If you filed taxes this year, you know, you had to show proof that you were insured for the past 12 months, or you got a penalty for not having health care. And we're going to discuss that some more later. That causes some problems as well. Okay, so outcomes management, and really all this is striving to have the most positive outcomes for every single person as possible. So how we do this is we have case management. These are the nurses who say, okay, you're in to have a baby and you're delivering vaginally and you should stay no longer than 48 hours. And if you stay longer than 48 hours, then they're the ones coming and asking the doctors and the nurses, why? Why are you still here? You had a normal delivery. There weren't any complications. You should be sent home by this time, because you only get paid a certain amount, regardless of if you spend 2 days in the hospital or if you spend 10 days in the hospital, you get the same amount of reimbursement. So it only makes sense, in order to maximize the dollars, that the mom and baby stay only the allotted amount of time. Now, this changes when you have complications, but for just a normal, healthy vaginal delivery, if you stay longer than 2 nights, then you're costing the hospital money. There are some studies out there about whether or not 2 days is long enough. Some women don't stay 24 hours. So there have been studies out there, and I actually have you an article on Blackboard that correlates discharge and the number of days in the hospital with infant outcomes, and whether or not we're doing the best thing by trying to get mom and baby out of the hospital as quick as possible. And you have to remember other things, other factors that play into that. The hospital is the worst place to be. It's full of germs. So yes, feasibly, if you don't have any complications, the longer you stay in the hospital, the chance of complications increases. So we want to get healthy mom and healthy baby out of this environment into their home environment as quick as possible to reduce those risks. We also use clinical pathways. Now, clinical pathways are guidelines for assessing what's the norm, what you should do if we're not in the norm, and how the timeline of care should look. So there is a clinical pathway for postpartum that is on Blackboard. So if you don't have it in front of you, pause the lecture, open it up. We're going to talk a little bit about it, and you really need to have this pathway in front of you, because it's about 4 pages long, and it really wasn't feasible to put this into the PowerPoint presentation. So if you need to go and pull it up and get it, do so now. But we're going to talk just a little bit about the pathway. So if you've got the pathway in front of you, it talks about clinical pathway for the postpartum period, and it gives you a category. It gives you the first 4 hours, 4 to 8 hours after birth, and then 8 to 24 hours after birth. So really and truly, we're looking at a healthy vaginal delivery for somebody that probably needs to go home after 24 hours. So what you have is, in your first 4 hours, you have all of these categories: comfort, nutrition, elimination, medication, discharge planning, family involvement, and then the date. So let's just look at the first 4 hours after you have delivered your baby. So it says comfort. So we're going to be looking at the perineal discomfort. And of course, if you've ever had a baby, you know you're squeezing out a watermelon from a hole the size of a pea. There's going to be discomfort. You've got stretching, you've got tearing, you know, those bones have to move, the ligaments stretch, the muscles stretch, so you're going to have discomfort. So what do we want to do the first 4 hours? Well, we want to make sure that we do perineal care. And this may involve sitz baths, or topical analgesics, because most of the discomfort is going to be in that superficial area around the vaginal opening. Hemorrhoids. A lot of women get hemorrhoids, and they have them also after childbirth from the pushing and the straining. Remember, when you're constipated and you push and strain, that can cause you to have hemorrhoids while you're pushing and straining to push the baby out, so it can cause you to have hemorrhoids as well. And you could already have hemorrhoids that have developed during your pregnancy. So once again, it tells you, what are we going to do for hemorrhoids? We're going to do sitz baths. We're going to do topical analgesics such as Preparation H or witch hazel. We're going to digitally replace the external hemorrhoid. If possible, we're going to push it back up into the rectum. We're going to make sure they lay on their side or in a prone position. After pains, after birth pains, we want to make sure that if you're prone, you have a small pillow under the abdomen, you do a warm shower or a warm sitz bath, and we ambulate. Of course, as with any other medical surgical procedure, early ambulation is critical. So it may be that we have, our mother has a PCA pump, or she just may have PO pain medicine ordered, and so therefore she's going to have to ask for it from you as the nurse, and you're going to administer it. But remember, some women won't ask for pain medicine. They feel like this is part of the process. They've got to endure the pain. I am a firm believer that if there's a medication available for it and you have access to it, why are you going to lay there and suffer? You don't need to be in pain while you're trying to bond with your new baby and you're dealing with your other children or your husband or your extended family. This is a joyous occasion. You want to feel good, and I'm not saying gorked out of your mind. I'm just saying comfortable enough to be able to sit and to talk and to cuddle with your baby and to speak with your family members or cuddle with your kids that you already have and not be grimacing in pain. Alright, so we move on down. You look at nutrition. It's got fluid requirements. You should be sipping on water, Sprite, eating crackers. We need to make sure there's bowel sounds before we start introducing food. Elimination. Of course, they should be urinating at least a minimum of 30 cc's per hour. So we would need to be doing intake and output. We put the hat in the toilet and tell the mom when she voids to please let us know so we can make sure she's voiding enough. Once again, pain medicines, stool softeners, and then discharge planning. And of course, I hope in most facilities, discharge planning has been going on since before the start of labor. We've told the mom what to expect, that she will be going home after 24 hours or 48 hours, that we don't stay in the hospital when we have a healthy baby in a vaginal delivery. You know, we need to get you home as quick as we can. We need to make sure you've got plenty of help. I know there's a lot of moms out there who go home and just go right back into taking care of kids and taking care of husband or family members and not having any time off to recover. We need to make sure that there's going to be somebody with her, her partner, her significant other, her spouse, her mother-in-law, whoever, a friend, who can just kind of help for the first few days. She's going to be sore, and you know, if she's had a cesarean, she can only lift the baby. So, you know, it depends on how she delivered, if there were any complications, but she really is going to need help. She needs lots of rest. This has been a very tiring event, and it's going to take her a few days to get over it. And then, of course, we have family involvement. We want the family to be actively participating, if not in the birth, then for sure after the birth, coming and visiting the baby, introducing the baby to siblings and to grandparents, and, you know, bonding with that baby and bringing the baby into the family unit. So, I just did the first 4 hours just to kind of give you an idea. You can look on. There's actually more categories as you scroll through. There's teaching, and of course teaching is huge. Management, activity, Referrals, you have to have a pediatrician to see the baby before the baby can be discharged. And then on the last page you have assessments, and it tells you vital signs, how often to do vital signs. The fundus, you've got to be able to palpate the fundus, see where it is it in the right place. Lochia, this is the bloody discharge that the mom has after birth. You've got to know what's normal. You've got to look at those peri pads and be able to say, okay, this is normal, or no, this is not normal, so that these findings can be passed on to your peers and to the physician. Vital signs, you know, what's normal, what's not normal. You should already know these. Cesarean, what to look for when the client has had a cesarean delivery. She's going to have a surgical incision. She's going to have staples or sutures. So she's going to have to be treated just like a med-surg patient in a way, because she's had surgery. So we've got to look for redness. We've got to look and see if the incision is well approximated. Is it bleeding? Is it infected? So once she delivers, she becomes that med-surg patient, and we have to monitor all of those things that we would monitor with our med-surg patient. So look over these. Now, it really depends on the facility that you work at, but most facilities follow best practices. And that means just about everybody does it the same way, because research and testing has shown that the evidence states that this is the best way to do it, and so most all facilities want to do it the best way that they can to decrease their chances of having, you know, unwanted risk or events that can cause problems. Okay, so home care, and this can be home care as in mom delivers at home, or it can be home care as in mom's been discharged and now we have to make sure that she knows what needs to be done. A lot of patients want to get home as soon as they can, because once again there's that cost factor. People who don't have insurance, you know, it costs anywhere from $5,000 to $10,000, depending on the facility and how long you're in the hospital, for a normal, non-complicated vaginal delivery. Now, that's a lot of money. If you don't have it in your bank account, then you're going to be paying on this delivery for a while. So the sooner you get out of the hospital, the lower the cost will be. So they want to control the cost. We have a lot of technology now that doesn't necessarily have to be used in a hospital setting. We have portable technology that we can use in the home for babies that have minor complications. You know, it just depends on what the need is, but normally we can get this technology out to the home and therefore decrease the time that mom and baby is in the hospital. The number of uninsured adults and children continues to rise, and we just talked about that. If you didn't have health care when you filed your taxes this year, you got a penalty. And I have an opinion about that, but we're not going to talk about opinions. But it's kind of hard when you do that to somebody who already doesn't have the money to get the insurance, and then you're going to, you know, put another monetary tax on them because they didn't have the money to get it. Then we have reduced access to preventative care. We're going to talk about poverty, but you know, these women who live in poverty don't have the access or the ability to access preventative health care, which includes prenatal health. And then it's costs more the longer you wait. So if we could have detected a problem early in pregnancy instead of it going all the way through until delivery, it's going to cost more once the baby's born than if we would have given this preventative care to the mother while she was still in the early stages of her pregnancy. So here is that article I was talking about on the length of postnatal hospital stay in healthy newborns and rehospitalization following early discharge. They did some studies to see if the length of stay had any impact on whether or not an infant or the mother was rehospitalized. So it's a really good article, so please read that, or at least scan over it. Okay, this chart is in your book, but this basically just tells you or gives you information about children, and then the amount of children or the number of children who live in poverty. And so depending on where you live, depends on the poverty rate, but the poverty rate in Alabama for two people is anything less than $15,930 a year for income. Now that's before taxes. So here the information is really given to you of less than $25,000. So you have to remember the minimum wage in Alabama is $7.25. That equates to about $15,080. So every single person, single mom, single dad, whatever, if they're working in the state of Alabama and they're making minimum wage, they are well below poverty level. Now that brings up this push for an increase in minimum wage. But just remember, if we increase minimum wage, then more than likely all of the products and services that we want are going to increase in price. So that's one of the things you have to look at when people are pushing for an increase in minimum wage, especially one that would double the current minimum wage. That would be detrimental to society. And I'm not saying people don't deserve that. Once again, this is all opinion, but we have to put it into perspective. And I know a lot of you have probably seen on Facebook or articles that if you push fast food workers up to $15 an hour, they're making more than soldiers, they're making more than firemen. So you really have to look at it like that. I think everybody deserves equal opportunity, but sometimes you have to strive to have something better, and that's what all of you guys are doing by going back to nursing school. You're striving so that you can get an education and you can have a better income. So looking at this, we can see that approximately 16% of children live in poverty. And then it breaks it down by age, it breaks it down by race, and of course there are disparities between race. We have a lot of Hispanics who are coming into the country who are not citizens. And so not being a citizen and not reporting their wages, then a lot of companies and people get by with paying them less than minimum wage. So they're going to be on the poverty level. But then you bring up other problems of, if you're not paying taxes, do you deserve to get all of the benefits of those who are paying taxes? And once again, that's a very sensitive topic that we're not going to discuss, but you have to think about how you feel about it. And if you were put into a situation where you are dealing with someone who is an illegal immigrant, whether or not they should be getting all of the health care benefits that those who are paying for it get. So just something to think about. There are some government programs that are just for children. Medicaid for children is called CHIP. And then there's also a program called All Kids Insurance Program. It's a reduced rate insurance program, and it only covers children. So if parents aren't able to provide insurance for themselves, they can at least provide insurance for their children to make sure that they're immunized, they go to the dentist, They're meeting their milestones as they grow, which are very important, and we will talk about those more once we get into PEDS. I did place a link for all kids on Blackboard under Introduction, so you can go there. Just look. I mean, you may not have ever heard of it before. You may know all about it. But it's something that if you're going to work in PEDS or in OB, this is something you need to be aware of. Okay, some health statistics regarding maternal and infant mortality, and this is just death rates. Mortality has declined dramatically in the past 50 years. So some of your parents and grandparents actually have better life outcomes when they were born, just by being born later in the last century, in the 1900s. So, you know, after about 1960, we really started making some progress. We started decreasing maternal and infant mortality. So we're living longer, and we're living past childhood, which is when a lot of mortality occurs, especially in countries that are underdeveloped. The same thing with moms. You know, prior to that they didn't know some of the things that we know now, and so the moms died during childbirth when really there wasn't a need to. So as of 2007, the maternal mortality rate was 10.2 per 10,000 births. Now that breaks down into African Americans had about 23.8, Caucasian Americans about 7.7. Once again, we have disparities. We have ethnic groups that have higher risk for certain disease processes. So not only is it the rationing of health care or of income, but it's also just the fact that some ethnicities carry higher risk than others. So we have to look at that. The United States ranks well above other developed countries. We are not the best, but we're pretty good. Infant mortality rates vary across ethnic groups. And unintentional injuries remains the leading cause of death in children age 1 to 19. So the infant mortality rate as of 2007 was 6.7 per 1,000 live births. So for every 1,000 babies born, about 6 or 7 died right after birth. Okay, the next few slides, I'm not going to read them all, but these are the Healthy People 2020 goals that are related to maternal, infant, and child health, and there are quite a number of them. For example, number 1, reduce the rate of fetal and infant deaths. You know, we don't want our babies dying. We want to make sure that our moms are giving birth to healthy babies who have a good chance at survival. We also want to reduce the rate of child deaths and adolescent and young adult deaths. So we will be looking at 3 and 4 when we talk about PEDS. So you can look over these. It's anything from birth weight to preterm, women who receive prenatal care, women who don't smoke, drink, or do drugs while they're pregnant. And that is a big issue. That's an ethical issue that we will talk about. Increase in the proportion of women who get the adequate amount of folic acid. And that's very important to prevent certain birth defects. Women delivering live birth who receive preconception care services. And what this is talking about is that women, let's go back, 50% of pregnancies that occur are accidents. Okay, now that doesn't mean they're bad accidents or the moms didn't want to get pregnant. It's just the fact of that the mom was not actively trying to get pregnant. So what we want to do is to make sure that those women who are of childbearing age, who want to have a baby in the future, that they are receiving care and preventative care to help improve the chances of them getting pregnant, staying pregnant, and delivering a healthy baby. And what to do, how to have healthy behaviors. We want to reduce relapse in smoking. That's a big thing. We want to, and this has been around for a while, but increase the proportion of infants who sleep on their backs. Sleeping on the stomach has been associated with SIDS, or sudden infant death syndrome. So, you know, back 20 years ago, we were telling everybody to put their baby on their stomach. Now that SIDS increased, we're telling moms to make sure their babies are on their backs. Now, that doesn't mean they don't need tummy time, but they don't need to be put to sleep on their stomach. We want to increase the number of babies who are breastfed, because breastfeeding is the best for the newborn to get immunity, to get the nutrients that they need. But of course, not every woman can breastfeed. So we just want to make sure that those who can do. All right, and we want to decrease the occurrence of fetal alcohol syndrome. That's another big thing. And I just read an article that shows that it's not just the mother's alcohol intake, but it can be the father's alcohol intake as well. That can genetically be transferred onto the sperm and to the child. There's not a lot of studies about that. That was really one of the first ones that I had read, and it was a very interesting article. Okay, so here are some more. Like I said, there's a lot of these. So we want to, this is our strive, this is our goal for 2020. You should be familiar with these, and I know someone in the group is doing one of the presentations about Healthy People 2020. So this may give you some ideas. And just a few more. All right, so next let's move on to ethical dilemmas. And as with a lot of the things that nurses do, we run into ethical dilemmas. We run into beliefs that contradict our own belief or contradict our society's belief. And so you as a nurse are going to be dealing with this, especially if you work with mothers and babies. And one of the biggies is abortion. How do you feel about abortion? Is abortion right or wrong? Are there certain instances where abortion is okay? This is a hot topic. You have to think about at what point is the fetus's life more important than the mom's life? Should women have control over their bodies and be able to abort a child if they want to? Now, I am a firm believer that if you can't have a baby, you shouldn't be telling me what I can do about my body and having a baby. So if we have female members of government who are making these decisions, I don't have as much of a problem with that as I do about the male members of our government trying to tell women what they can and can't do with their bodies. This is something that women have been struggling with since the dawn of time. So, how do you feel about contraception? Do you think that contraception's okay? A lot of cultures and religions don't think that contraception is okay. For example, the Catholic Church frowns upon contraception other than the rhythm method. And if you don't know what the rhythm method is, you need to look it up. So, prior to this century, I could see the relativity of that statement because we had a very high infant mother mortality rate, and in order for our species to survive, we have to have women having babies. So, that being said, we now live in a time where the majority of our babies survive. The majority of our mothers survive. So we have a surge, an increase in population. And at what point are we going to run out of resources if our population continues to grow at the rate it has been growing for the past 100, 200 years? So those are things to think about. You know, once again, these are personal decisions that you have to make, and you need to look at them now. Because if you work in OB/GYN, you are going to face this dilemma about abortion. Whether or not it's right or wrong, I don't think it's up to us to decide. I think that that's the mother's decision. Does the father have any rights? That's a whole nother touchy subject. Yes, the father has rights, but when the health of the mother is at stake, the father is more worried about the child than the mother. I have a problem with that, because mom can have another baby. But once mom's out of the equation, then that means you've got to find a new female to have your babies. So, you know, there's some issues there. But once again, you know, those are opinions that you have to look at. You know, a lot of religious groups think that that the fetus is a human being the day of conception. Some people think that the fetus is a human being once you hear the heartbeat. Some religious groups don't see the baby as a viable human until after it's been born and been alive for a certain amount of days. There are a lot of cultures that don't name a child until they're 2 weeks old, because in the past we have had such a high rate of infant mortality. Okay, so if you go to work somewhere and they do perform abortions, you have to state whether or not, or what your opinion is on that, and you have to find out what the employer is going to do if you refuse to be involved in an abortion. Now, number one, I would encourage you not to get a job somewhere. If you're against abortion, you don't need to be working at a Planned Parenthood clinic. Okay, that's just common sense. And what are the punitive approaches to ethical and social problems that may prevent patients from seeking care? For example, a woman who is pregnant from rape or from incest. These are ethical and social problems, and she may or may not come forward simply because she was raped. You know, there are many cultures that blame rape on the female, and I have an opinion about that, but that's another story. So those are other things that you have to look at. You know, we have to really think about what is the right of the female related to her body, because she's the one that has to carry the baby. Okay, poverty. We touched on this just a little. 21% of children live in poverty. We talked about that. Poverty level for 2 people is about $15,900. Poverty level for 4 people is about $24,000. So think about a mom, a dad, and 2 kids. We said minimum wage is $7.25 in Alabama. That's about $15,000 a year before taxes. And the average cost of health care in Alabama is $217 per month per person. So that equates to about $2,600 a year for insurance for one person. So you start doing the math and you can see that if it's a choice between insurance and food, well, food's probably going to win. And I don't know that I believe in the fact that the government is going to penalize me because I can't afford insurance. But then that raises the question of using those medical resources and you haven't paid into the system. So it's a very vicious cycle. Allocation of resources. we know that there is a problem with healthcare rationing. People who have money have really good health care. People who don't have money don't. And it's just as simple as that. People in cities have access to more diverse care than those living in rural areas, which tend to have more people in poverty. Government programs. We have government programs in place, but of course there are people who use the government programs judiciously, and then we have those who live off government programs. Indigent women and children, the care for them. You know, it's hard to work if you're pregnant, you know, every year. You can't hold a job. So these are the people we need to be reaching and trying to educate, and trying to give care to, and decreasing the mortality in these women, these infants, and these children. Okay, this was just an example from your book. I've read articles on this before. If a child is born into poverty, they're more likely to be poor as an adult. Poor children are more likely to leave school before graduating, either to get a job or because they don't have the resources in order to learn. They don't have the family support in order to learn. Childbearing at an early age is more common in poverty. And of course you get into that vicious cycle of, if you're pregnant, it interferes with going to school and your ability to work. Another thought is that if a mom is a teen mom, then her child is more likely, her female child is more likely to be a teen mom herself. Okay, so a question. To assess a mother's risk of having a low birth weight infant, the most important factor for the nurse to consider is African American race, cigarette smoking, poor nutritional status, or limited maternal education. For this one, the factor is race. Race plays into a factor of having a low birth weight infant. Okay, informed consent. You should know what informed consent is. We've had it before. You know that we have to have consent before we do any type of medical procedure. So informed consent should be familiar to you. We have to disclose all of the risks and benefits of a procedure that requires consent. We have to make sure that the client understands what we're telling them and that they're competent enough to understand what we're telling them, and that we are explaining things in terms they can understand. Now, consent must be voluntary. We can't force somebody to have a procedure that they don't want to have. That's their right to refuse. Parents must consent for a minor child. Now, this is where we get into some legal and ethical issues. The age of consent in Alabama is 16, and that basically is sexual consent. But you're a minor until you're 18. So until you're 18, you have to have the consent of your parents for medical treatment. Now, of course, there are some episodes or examples where that is different. The child is emancipated, and they don't have to have the consent of their parent. Now, there is an exception. You do not have to have the consent of your parent if you're under 18 and over the age of 12 for an abortion. Now, that, of course, brings up a whole nother ethical bowl of soup that you, I'm sure, have an opinion on, and everybody has an opinion on. So, adolescents have to give consent for treatment related to sexually transmitted diseases. So, a parent couldn't say, no, they're not going to be treated. No, they can't have contraception. Or if they're being treated for alcohol and drug abuse, because those are things that people need treatment for without somebody else telling them. Now, of course, contraception and sexually transmitted diseases are going to be biggies in this course. You're going to have scenarios where it's going to be a major ethical dilemma for you to decide what's in the best interest of your client. Okay, accountability. We all know what accountability is. That means that we are accountable for our actions, whatever we do. We have to know that if there are consequences, then we have to deal with the consequences if they occur. You have to be accountable as a nurse to practice within your scope of practice. So you should know your scope of practice for your state, standard of care, and then you've got to know what the policies and procedures are for care in the facility that you work in. Legal issues, we have to look at malpractice and whether or not you as a nurse or a nurse did something that caused harm to a client. Did you maybe not follow the informed consent? Did the patient refuse the care? And this is a big one, because yes, clients can refuse care, but we have to make sure that the clients understand the consequences and that we tell them the consequences in words they can understand. The best way, the best defense against malpractice is documentation. If you document that you educated the patient on their risk for getting an STD by having unprotected sex, then when they come back and say, well, I got an STD and nobody told me that I could get this from sex, then your documentation is going to prove that, yes, you educated them, they stated they understood, and therefore you wouldn't be held liable. Now, that's not a really good example, but you can see where I'm going with this. And maintaining their level of expertise. If you're a nurse, you've got to stay up to date. You can't just say, well, this is how we've always done it, because things change. Evidence-based practice changes, so you have to stay current with what is the best practice. And you may be the one telling your facility, hey, this is not the best standard of practice. We're not using the best evidence-based practice for our clients. And you may be the change that's needed in your facility to help bring them up to par. Now, that doesn't occur as much as it used to, but it still does occur. So stay current. Whatever field of nursing you decide to practice in, you've got to stay current. You've got to make sure that the care you're giving your clients is the best care that you can give. So we talked about this. Documentation is the best evidence that the standard of care was met. So when you do something, when you put in an IV, when you put in a Foley, you document that strict sterile technique was used. It took 1 attempt, 2 attempts, patient tolerated, you educated them about it, so when it comes up in court, they have that documentation that says, yes, you supported that standard of care and you did what you were supposed to. So it's got to reflect the care given. It can't be vague, patient positioned for labor. Okay, what position were they in? You have to be specific. You have to give specifics about what position they're in, especially in surgery, because certain positions carry greater risk than others for having injury. Delegating to unlicensed assisted personnel or to LPNs. You've got to make sure that you know what can be delegated and what cannot. And then know your recommendations of state licensing boards. You should already, at this point, have at least accessed the Alabama Board of Nursing website and know what's on there. I know you're not a nurse yet, but you're studying to become a nurse, so you should be familiar. That website should be bookmarked on your computer from now until the day you die. If you're going to be a nurse, you need to know what recommendations for whatever state you practice in, you should be up to date. Okay, so let's move on to Chapter 2. So, the role of the professional nurse. It's really the same in OB and Peds as it is anywhere else. You're a care provider. You actually do treatments. You give medicines. You change dressings. You teach. You're going to teach your client ways to be healthy before they get pregnant, while they're pregnant, and then once they deliver. So you're going to always be teaching. You're going to collaborate. You're never going to be the only person taking care of a client. There's going to be the NICU nurse, or there's going to be the obstetrician, or the pediatrician, or the social worker, or the dietitian. You always will be collaborating with some other professional when you care for clients. A researcher. You're going to promote knowledge. You're going to always need to be knowledge seeking to make sure you're doing what's best for your client and what's best for the outcomes for your facility. An advocate. You're going to advocate for your client. You're going to make sure that you speak out on behalf of the client if you see a wrongdoing, or if you see a peer not following the standards of care, or if you see a family member who is mistreating your client. You've got to be an advocate for that client and speak up, especially for the young and the infirmed and those who can't speak for themselves. A manager, and this is becoming more and more of a role in nursing because patients are staying in the hospital shorter amounts of time, but they've got a lot more problems going on. They've got all these comorbidities, but they're not staying in the hospital very long. So you have to maximize the benefits and the time that they're at your facility. Okay, so some of the care settings you're going to see with OB and Peds, of course, the hospital clinics, physicians' offices, home health care agencies, school nurses. You saw that this past semester, rehab centers, camps, daycares, hospice. All of these things touch the lives of women who are pregnant, becoming pregnant, had a baby, or have children. This is a lot of the places that you're going to see those. An advanced practice nurse, you can become an advanced practice nurse with an emphasis on either pediatric, women's health, neonatal. Those are all types of nurse practitioners. Now, certified midwives in Alabama, this is not very common. And I did put an article on Blackboard that talks about midwives in Alabama and who's for it and who's not. So it's not a very long article. It's about 1 page. But it gets the view of the physicians and of the moms that want to use midwives, and then of midwives. And then we can have, advanced practice nurses can work in offices and provide care for women and children. And one of the places we see this a lot is in the NICU. Most NICUs, which is the neonatal intensive care unit, use advanced practice nurses to care for these really complicated infants. Or you have to be certified in neonatal in order to work in some of these NICUs that we have. They have these really, really sick babies. You can sit for your clinical nurse specialist certification in family, peds, neonatal, and perinatal. And what a clinical nurse specialist does is they are usually the educators, the researchers, the consultants, people that we bring in when there's a problem or there's a complicated case that needs complicated care resources. So they provide in-depth intervention for problems encountered in maternity and pediatric care. Okay, so communication techniques. Most of these you should know what they are. If you're not quite sure about them, you need to look them up. Critical thinking, well, this is what you've been learning for the past 2 semesters, and we're going to be doing a lot of critical thinking activities in class. This is why a lot of your lectures are going to be online, because we just don't have the time to do the content part, the part you need to memorize and know, and learning how to apply this to real life situations. So this is a big part of your nursing school career. You know this. You've had it on test. So we're going to be doing a lot of this, recognizing assumptions, examining biases, analyzing the need for closure, managing data, and then emotions and environmental factors. So the nursing process, you should know the nursing process. If you haven't learned it already, you're behind. So you need to learn what the process is and the steps involved in the nursing process: assessment, nursing diagnosis, planning, implementation, and evaluation. Okay, complementary and alternative therapies. Of course, we are going to run into patients who use these therapies. We have to remember that there is a safety concern. There are complementary and alternative therapies that conflict with certain medications, certain disease processes. But with that in mind, we have to remember that the patient has the right to use these therapies, especially if they believe them to be helping. So we can't just discount these therapies just because somebody says they don't work, or you think they don't work, or I think they don't work. It's what the family thinks. We just have to keep the client safe. Okay, so a question about the nursing process. The nurse is establishing several health programs, such as a bicycle safety, to improve the health status of the target population. Which step in the community nursing process is this? And the correct answer is implementation. Okay, nursing research. We don't do a whole lot of nursing research as ADM prepared nurses, but we do follow the trends of nursing research, such as the evidence-based practice. Everything that we do because some researcher did all of these tests and decided that hand washing was an extremely important way to prevent the transmission of disease. So, somebody out there did the study, decided this is what we need to do, and that's why we use evidence-based care. Relying on traditional care methods is no longer sufficient. Just because this is how we've done it for the past 50 years doesn't mean it's the best way to do it. Nursing research, this is a rapidly growing field. It is still mainly in its infancy, childhood, I would say, and it's going to just get bigger. Now, the next one, the Association of Women's Health Obstetric and Neonatal Nurses. I've given you a link to this website. If you are interested in working in this field of nursing, then I would recommend you go to this website, and it kind of gives you an idea of what goes on, the best practices, what's going on in these areas of study. And then, of course, we have the National Institute of Nursing Research. Okay, so principles of teaching and learning, you know these. You've already learned how to teach and to educate your client. You know, the client has to be active in participation. The best way to know if a client knows how to do something is if they do a return demonstration. So all of these things you have done, providing feedback, praise, repetition of the skill, just like you as a new nurse, you get better with a skill the more times you do it. The more times you try to start an IV, the better you'll get. Same way with our clients. Using a variety of teaching methods, and all of you know this, not everybody learns the same way. You may have to change your way of teaching in order for your client to get the maximum benefits. And remember, you've got to space out information. We're used to getting lots of information, but a mom who already has 3 kids and has another one on the way, we're probably going to have to do a little bit of teaching at a time, especially if this is a new problem she hasn't encountered before. This baby's going to be born with some kind of problem and she's never dealt with that before. She has a lot going on in her life, so she may not can take a whole lot of information at one time, and we may need to spread it out. Okay, so chapter 3, this really is talking about families. What kind of families we are going to come in contact with childbearing. And believe me, you're going to come across a lot of different kind of families. Some types of families you may never have seen before. So we have traditional families. These are families where you have a mom and a dad and kids. One parent works, usually the dad, in the single income. Mom stays home, takes care of the kids. Now that role has reversed in the past few years. There's a lot of stay-at-home dads now because women are becoming more and more educated, and we may have more education than our husband or our spouse, and we have the better paying job, so therefore we go to work and dad stays at home with the kids. But the most common type of traditional family that we see is the dual income. Both parents work. And in life today, and you know it takes 2 incomes if you want to get anywhere in life and have anything. So, more likely than not, mom is pregnant, she's working, she's going to work up until the day she delivers. She's going to deliver, she's going to stay at home for 8 weeks, and then she's going to go back to work. Now, that's how it's done here in the United States. In other countries, some women get up to 6 months off. Here in the United States, most dads only get a week off with the birth of a child. They don't get 6 weeks to stay at home and help out with the kids and with the new baby. So those are things you have to think about, especially with families who don't have any relatives living in the general vicinity, the same state, the same city. You know, what kind of resources are they going to have? Okay, so some other types of families include your non-traditional families. And this may be your single parents. You've got a divorced couple and one parent has custody of the kids and does the majority of the care. Blended. This is where you have 2 divorced people who marry, each of them bringing kids from their respective marriages and blending them into one. Adoptive. This is where you don't have a biological child, but you have an adoptive child. Multi-generational. And we see this a lot with our Asian families, with our Middle Eastern families. They have multiple generations living under one roof. You've got mom, dad, you've got grandma, you've got cousins, whatever, living under the same roof. You can have a polygamous marriage where you have one dad and several moms and there's lots of kids. And then, of course, we have our same-sex partners who choose to have a child either by conventional or non-conventional means or adoptive, but we're seeing more and more of that as well. So, high-risk families. These are families that are going through divorce or have divorced or there's marital discord. You may have violence in these types of families. Adolescent parents, these are really high risk. They don't have jobs. They may or may not have support of their parents. They don't have the life skills needed to care for and raise an infant. They just don't have the experience. Substance abuse. We see this a lot. And I've seen parents, just like in this picture, who don't think anything about smoking and whatever in front of their child, and the child grows up believing that that's okay. Illness of a child or another family member. If you've got a child who's got cancer or a mom who's got cancer, then those are high-risk families. Stress. All of you know what stress is. You know that everybody deals with stress differently, but there are healthy ways and unhealthy ways to deal with stress. You know, we can have dysfunctional family patterns. So everybody has seen some type of dysfunctional family, be it in real life or on TV. You've seen it. Anything from The Simpsons to, I don't watch a lot of TV. I'm sure there's some other shows out there that have dysfunctional families. But most of you have seen this sometime in your life. Okay, cultural diversity. The United States was born on the premise of cultural diversity. We wanted people from all over the world. If you wanted freedoms, if you wanted religious freedom, that's what the United States is built on. And a lot of people have forgotten that. They think that the United States should be majority white or majority black or whatever. No, we are a melting pot. So we're going to see all different kinds of patients from all different kinds of culture. Now that being said, there are many different beliefs tied to these cultures and these ethnic diversities. And they can include health practices, illness prevention, health maintenance, birthing and child rearing. There are a lot of different views on birth and child care depending on where you're from. And we'll talk more about this in class on Thursday. And also remember that we have women and men who are having kids later in life. They're going to college, they're getting their degree, they're starting to work on building a house, things like that before they decide to have a child. So now we have these women who are having their first baby in their 30s and 40s instead of having their first baby in their 20s. So when you're caring for your client, you're going to have to do a cultural assessment. Now, yes, still the majority of your clients are going to be from the United States. They are going to be white, black. They're going to have basically the same values, practices, customs, and beliefs as you do. But if you work in certain cities and certain states, this will be different. We do come across language barriers with these cultures. This has been especially a problem with the Hispanic population moving into the United States. They don't speak the language, but they say this is only going to be a problem for about the next 5 to 10 years because they're having children and their children are bilingual. They know English. Now, the United States doesn't have a preferred language. One was never set when the founding fathers were founding this country. So you have to be careful when you say if you come to the United States you should speak English, but you have to remember that we don't have a set language. We never have had a set language. It is just more common to have people speak English. So religious and spiritual beliefs. You know, there are certain cultures where men cannot be present with the birth of a child. That is the women's role. Mom can't eat certain things, or they may be vegetarian, or with health promotion, they may use more of the alternative medicines than our traditional medicines. And they may not know what the role of the healthcare professional is, and that we are there to help the best way we can. And that means doing things that are what the client wants us to do. Okay, so ethnic groups, the most common ethnic groups in the United States, of course, African American, Amish, Arabic, Hindu, Jewish, Mexican or Hispanic, American Indian, Caucasian, Euro-American. These are the most common ones that you will see. So religion breakdown. Christianity is still the most dominant religion in the United States, but that's changing. We have more people than ever who don't associate with any type of religion. We've had an influx of Hindu and Buddhist, Jewish. Catholic is the second largest. Excuse me, my phone is ringing. Okay, sorry about that. I'm back. Okay, so we need to look at, when we look at cultures and ethnicities, we need to understand that this all is like an iceberg, like you see on your screen. And behaviors reflect the things you can't see. Okay, you may not be able to see what their religion is just by looking at them, or their beliefs, or their values, or their history. But the physical manifestation of those things are the behaviors that we have when we're around other people. Alright, so let's talk a little bit about parenting styles. You're going to run across all different kinds of parents if you work in OB and Peds. You're going to run into the really strict parents, the permissive parents, kids that run wild, kids that are well behaved. But basically, we can refer these parenting styles back to about 4 styles. Now, the first one is authoritarian, and this is basically the parents make the rules and they expect the rules to be obeyed no matter what. There is no room for discussion. Authoritative basically allows for some discussion or negotiation. If a child doesn't understand or agree with a punishment or a rule, then the parents are open to discussion and negotiation to try to help the child to understand. Permissive means there is very little control. The kids pretty much do what they want to do when they want to do it. Hands off is just an even more extreme version of that, in that there are no rules at all. There is no control at all. There's chaos, in my opinion. So here's a question, and I want you to look at this question and see which one of these you would choose. Now, what I'm looking for is for you to choose the one that would be the permissive parent. And remember, the permissive is little or no control. So, you read this and you've decided on an answer. And so I want you to pick the permissive parent. The correct answer is B. This is the permissive parent. Alright, in this question, you and your daughter have been doing errands all Sunday. You both come home tired and cranky. Your daughter has homework and she announces she needs lots of help. And despite your throbbing headache, you say this. In this one, we are looking for a hands-off parent. No rules, doesn't matter. And that parent is going to be D. Alright, this question, we are looking for the authoritarian parent. And this is the parent, remember, who there are rules, but you allow for some negotiation. So this parent would be B. All right, and then the last one, we're looking for the authoritative parent, the one, it's my rules, my way, you know, sorry, the authoritative parent. So this would be C. Okay, so temperament and parental expectations. So this is how the child acts. These are the types of kids we have. We have easy, difficult, and slow to warm up. So the easy child, this is just like it sounds. They're even-tempered. They're predictable. They know the rules. They know what to do in social situations. They know how to act. Their parents have given them boundaries. Difficult, these are highly active, moody, and they have irregular habits. They may or may not take naps when they're supposed to. They may or may not go to bed when they're supposed to. And then you have your slow to warm up. They're not active, but they're moody. And they do have some moderately irregular habits. So these are the three types of children that we're going to deal with. The next thing we have to look at is how parents deal with misbehavior. And we all know parents deal with misbehavior very differently. And I am not a parent, so I am in no way a professional on this. I do have an opinion though. So let's look at redirection. These parents remove the problem and distract the child. So this is really good for like infants and preschoolers. You know, something's made them mad, you remove that object or person, and then you distract them with something else. Reasoning. This is when you explain why a behavior is not permissible. And you really want to use I and you messages. Now, timeout. We've all heard of timeout. This is where you stop what you're doing, you stop the child, and you take them to a predetermined place and you sit them down and say, you have to sit here for 3 minutes. No sounds, no noise, no playing, no whatsoever. So you remove the attention from the child. If the child was acting up, then if you put them in timeout, they're not getting that attention anymore. But you have to remember that the time length must be appropriate for the child. And a good rule of thumb is 1 minute for however old the child is. So a 3-year-old should be able to sit in timeout for 3 minutes. A 5-year-old for 5 minutes. Now, I know that doesn't sound like a lot of time, but remember, those children, those very young children, only know what's happening right then. They don't associate what they did an hour ago with their punishment that's going on right now. So you have to immediately do the timeout when the child is misbehaving so that they know you did this, so you get timeout. Consequences. You know, there's results for behaviors. If you stay out late, you will be grounded, and being grounded is the consequence. Behavior modification, this is where you reward good behavior and you ignore bad behavior. Now, that doesn't always work. And then we have corporal punishment, which is physical punishment for misbehaving, such as spanking, you know, paddling, whatever you want to call it. And of course, you know, there is a lot of controversy around parents and corporal punishment. Okay, so structure and function. So we have these different functions. So affective function is our psychological needs. Children have to learn to trust that they'll be nurtured, that their family will bond with them, that they will provide those psychological needs. Socialization just is that they're going to be productive members in the society. So they have to learn how to act and interact with society and what things are permissible and what things are not permissible. Reproductive function, this is societal survival, and this just means that we have to have continuation of the species. We have to have that reproductive function in our society in order for our society to live on. Now, economic function, this is the allocation of economic resources. So this is the ability for you to earn or get resources and use them to support your family. And then healthcare function, this is provision of physical necessities of life. This is the ability to know when a family member is sick, when your child is sick, promoting healthy behaviors such as making your kids brush their teeth, using preventative medicine to prevent certain diseases from happening, such as immunizations, which is a hot topic as well. Alright, so we have a question here. When discussing the discipline with the mother of a 4-year-old, the nurse should include which of the following? And the correct answer here is that parental control should be consistent. So whatever type of parent they are, they should be consistent within that type of parenting. Alright, so this is the end of the introduction to this class. You will also need to watch the lecture, the next lecture, which is going to be antepartum, which is going to include conception, prenatal development, and those things. All right, thanks.